Welcome everyone. In today's video, we are going to discuss the examination of spine. Examination of spine consists of local examination of the spine and neurological examination. The headings in the examination of spine are inspection, palpation, movements, and special tests. The neurological examination consists of higher mental function, examination of cranial nerves, motor examination, sensory examination, autonomic system, cerebellar function, and meningeal signs. Now let us have a look at the local examination of spine. So it starts with inspection. So first we have to know what is the position in which we have to examine the patient. The ideal position is standing position if the patient is able to stand. However, there are some conditions in which you will avoid the standing position. And what are these conditions? These are conditions in which there is a risk of neurological deficit due to standing. The examples are any acute infection like tuberculosis, acute traumatic fracture, or a gross instability of the spine. So in these patients, you have to examine in a prone position. So most cases standing, in some cases prone. What is the role of lateral decubitus position? It is for quick examination by log rolling when there is a patient with an acute trauma in an acute trauma setting. So when a patient comes with acute trauma, you're already doing your ATLS and you do want to do a quick examination of the spine. You log roll the patient and examine in lateral decubitus position. The role of sitting position is when there is a scoliosis due to limb length discrepancy. So if there is a scoliosis, you examine in sitting position also, and any scoliosis due to limb length discrepancy disappears in sitting position. So the examination starts with gait. You have to describe the gait, whether it is assisted or unassisted, and you have to describe the swing phase and stance phase and the movements at the different joints during these phases. If you can identify any pathological gait pattern, you can mention that pathological gait pattern. Some of the common pathological gait patterns associated with spinal problems are high stepping gait, which is associated with foot drop, stamping gait with a dorsal column lesion, and spastic gait with conditions like cerebral palsy or spinal cord injury with spasticity. Following the gait, we have to describe the attitude of the patient. If the patient is able to stand, we describe the attitude in both standing and lying down position. Describe the position of the head and neck and any obvious change in alignment of spine like kyphosis or lordosis in the sagittal plane or any obvious list or scoliosis in the coronal plane. Also comment on the position of hips and knees. We also can describe any specific position the patient has adopted to relieve his pain. Now here you are often asked the difference between list and scoliosis. So list is a sudden and abrupt shift of the proximal spine or trunk, whereas scoliosis is a sideways or lateral curvature of the spine. So a sudden abrupt shift is list and a lateral curvature is scoliosis. List is usually an uniplanar sideways tilt, whereas scoliosis is a multiplanar deformity with a rotational component. A list is indicative of an intervertebral disc pathology. In scoliosis, you will have a rib hump due to the rotational deformity. So scoliosis often will have a rib hump due to rotation of the spine, which will not be present in a list. You are also asked the presentation of the disc depending on the side of the list. So if the list is to the same side as the pain, it is indicative of an axillary pathology, whereas in an opposite side it is indicative of a shoulder pathology. So a way to remember is, see, when the patient is tilting to this side, the space in the axilla increases. Now this position is assumed to relieve compression. So to the same side, space in the axilla is increased. So in an axillary disc, the patient will have the list towards the same side. So same side axillary and opposite side shoulder presentation, and this is how you can remember it. Following this, we do the inspection from the back. Now there are a lot of points here and it can be a little confusing, but if you keep following the patient from top to down, you will not miss any point. So the first thing you look at is the position of the head. Then you look at the hairline, whether the hairline is normal or it's a low hairline. So an example where patient may have a low hairline is Klippel Field syndrome. Then comes the neck. So you look at the neck length and alignment. Alignment can be disturbed in scoliosis, and neck length again can be decreased in Klippel Field syndrome. Next is the shoulder. So you look at the level of the shoulder, which can again be disturbed in scoliosis. Then you look at the level of the scapula. In scapula, if the spine is seen, you can look at the level of the spine and the inferior angle of the scapula. So spine and angle of scapula. After you have seen these levels, you look at the any deformity in the coronal plane of the spine itself. So any scoliosis or list, then you observe. You also observe the lateral margin of the trunk, which gives you an idea about the scoliosis. Then in the back, you have to see if there is any obvious swelling, any scars and sinuses, and any signs of underlying cord anomaly like a tuft of hair, dimpled or puckered skin. If you can see any swelling, you have to do the inspection of the swelling as per how you examine the swelling. After this, you look at the central furrow. The central furrow is deep in muscle spasm and shallow when there is a wasting of the paraspinal muscles. Following this, you see the level of the PSIs or the dimple of Venus, and you comment on the natal cleft, whether it is central or not, and the gluteal folds. If there is any scoliosis, you have to describe the scoliosis. Describe the curve based on the location, convexity, and the apex. So you describe in which location the curve is, which side the convexity is, and where is the apex. So curves are described based on the location of the convexity. So if the convexity is towards the right side, it is a right-sided curve. In the thorax, it is a thoracic curve based on the apex, which is the vertebra which is farthest away from the center. Then you see the patient in a sitting position. If there is a limb length discrepancy or a hip deformity which is causing the scoliosis, it will disappear in a sitting position. Following that, you do the Adams forward bending test. You ask the patient to bend forward. This is to distinguish structural and functional scoliosis. A structural scoliosis will become more prominent due to the rib hump on Adams forward bending test, whereas the functional scoliosis will disappear. So you see if there is any rib hump. Here we can see the scoliosis has become more prominent on bending forward, and you can see the rib hump properly. This is a marker of structural scoliosis, and it occurs due to the rotational component of the scoliosis. To see the coronal balance, you can drop a plumb line from the C7, and normally in a balanced spine, it should be between 1 to 2 centimeter of the midline. The next thing you have to do is inspection from the side, where you have to comment on the cervical lordosis, thoracic kyphosis, and lumbar lordosis, and look for any abnormal lordosis or kyphosis. Kyphosis may be angular or rounded. Kyphosis is also divided into knuckle, gibbous, and kyphus. Knuckle is when one spinous process is involved, 2 to 3 is gibbous, and greater than 3 is kyphus. Also in the lateral position, you look for any swelling in the lateral part of the neck. This is followed by inspection from the front. Here we have to look at any chest wall asymmetry like pectus carinatum, which can be seen in long-standing kyphosis. Pectus excavatum is usually not due to spine pathology. From the front, you also look at the level of the ASIS, which can be higher or lower, both in cases of scoliosis and abduction, adduction, deformity, which then has to be checked. Following this, we come to palpation. In palpation, we always start with confirmation of inspectory findings, and we have to check local rise of temperature with the dorsum of hand and any localized tenderness. Different type of tenderness are there in the spine. The first is direct tenderness. Here, with your thumb, you give pressure over the spinous processes. This is more indicative of a posterior disease or a very advanced anterior disease. If there is direct tenderness in the intervertebral space, this is indicative of a disc prolapse. The next type of tenderness is rotatory tenderness. Here we have to stabilize the adjacent spinous process and give rotatory force on the spinous process. So we can stabilize the spinous process above like this and then rotate the spinous process below to look for rotatory tenderness. This is for early detection of anterior disease, and it will also be positive in posterior disease. So if you are asked which is more specific for early detection of anterior disease, it is rotatory tenderness. The third is thirst tenderness. Here you give gentle thrusts on the back of the spine with a fist, and this is for both anterior and posterior disease. You may be also asked what is whole swath test. So a whole swath test is like a screening test. Here you try to quickly localize the area of pathology. So you run your fingers down from the top of the spine to the bottom of the spine, and any area of tenderness can be localized with this quickly screen, or any obvious deformity also can be quickly screened by this test. Next step in palpation is you palpate for any step in the spine which can be there in spondylolisthesis or any acute fracture dislocation. Any deformity that you found in inspection has to be clearly defined as per the vertebral level in palpation. So in palpation, you usually mark the spinous processes in the patient. So how do you mark? There are some landmarks. The landmarks are C7 is vertebra prominence or the first prominent vertebra. T1 is the longest spinous process. T3 corresponds with spine of scapula. T7 with inferior angle of scapula. L4 with the highest point of the iliac crest, and S2 with the posterior superior iliac spine. So you can remember these landmarks and mark the spinous process according to these landmarks, and now you can clearly define the deformity or the location of the deformity, whether there is any gibbous, kyphus, or what is the level of scoliosis, or what is the level of tenderness. Everything you can define once you mark the vertebra. The next is muscle spasm. So you can also palpate muscle spasm. The methods are tapping over the muscle, so you can see any contraction of the muscle. You can put direct pressure of the spinous processes and you can see any visible painful contraction. And there is also one test called as the Kibler test. So you pinch the skin over the paraspinal muscle and you try to move it along the axis of the paraspinal muscle. So when you pinch the skin and try to move it along the axis of the paraspinal muscle, this movement may be restricted when there is a paraspinal spasm. This is followed by palpation of the swelling. So if there is any swelling, you palpate according to how you palpate a swelling. Now some of the location where swelling may be present is neck in case of a retropharyngeal abscess, anterior chest wall or axillary area in thoracic lesions, especially tuberculosis, iliac fossa, lumbar triangle of Petit, and lumbar upper thigh in lumbar involvement in pot spine. The next thing we check are the movements. In the cervical spine, the movements are flexion, extension, lateral flexion, and rotation. So, in flexion, normally the chin is able to touch the region of the sternoclavicular joint. We can also measure the chin to chest distance. For measuring the degree, we can place a spatula in the mouth and measure the angle the spatula makes with the horizontal. So the normal range of flexion is around 80 degree. Similarly, again for extension, we ask the patient to extend. Normally the plane of the nose and the forehead is usually horizontal. We can again place a spatula here and measure the angle with the horizontal, and the normal range is around 50 degree. We can ask the patient to bend to the side to check the lateral flexion. The normal range is around 45 degree, and rotation is measured from the coronal plane, and the normal range is around 80 degree. For the dorsal-lumbar spine, for checking flexion, we usually take the finger to floor distance, and a normal finger to floor distance is usually less than 7 centimeter. We can also describe how far down the lower limb the hand can reach. So like we can describe the hand reaches up to the knee or mid tibia, something like that. And this flexion is usually a combination of flexion of dorsal-lumbar spine and the hip, which cannot be isolated here. Other method of checking flexion are the Schober and modified Schober test. This is again very important. So for this, we mark the PSIS first and put a mark here. For Schober test, we put a mark 10 centimeter above this line and ask the patient to flex. And if the increase in the distance is less than 5 centimeter, we call it a decreased spinal flexion. In modified Schober test, we mark 10 centimeter above and 5 centimeter below and then ask the patient to flex. And here also a increase of less than 5 centimeter is known as decreased spinal flexion. Now some people say the modified Schober test is more accurate for the measurement of spinal flexion compared to the Schober test. So in Schober it is only 10 centimeter above, and in modified Schober it is 10 centimeter above and 5 centimeter below. Ask the patient to flex and look for the increase in distance. Less than 5 centimeter is abnormal. For the dorsal spine, the test that is described is OTT test. It is similar to Schober. Here we mark the C7 and mark a point 30 centimeter below. Ask the patient to flex forward, and normal is more than 3 centimeter. For extension, we ask the patient to arch back while stabilizing the pelvis. And the normal range is around 30 degree. However, exact measurement with a goniometer is very difficult. For lateral flexion, we ask the patient to bend towards the side. We can measure the distance from the floor. Also, we can describe the point reached on the leg like we described in flexion. And for the angle, we draw a line joining the S1 and T1 and a vertical line. So one limb of goniometer will be placed here, one limb along this line joining the S1 and T1, and the angle that it measures is the lateral flexion. For rotation, we ask the patient to rotate in the dorsal-lumbar spine, and we place the goniometer one limb along the pelvis and one limb joining both the shoulders. So you ask the patient to bend like this. One limb of the goniometer has to be along both the shoulders and one along the pelvis, and you get the rotation. The rotation in thoracic spine is almost entirely thoracic, and the normal range is around 40 degree. The next thing that we measure is the chest expansion. It is done in the fourth intercostal space at the level of nipple, and it is done in full expiration and full inspiration. Normal in a healthy young adult is around 6 centimeter, and less than 2.5 centimeter is highly suggestive of ankylosing spondylitis. Next, we have to describe the special tests. So the most important among these is the straight leg raising test or the Lasegue test. Here the patient is lying on a couch and you passively raise the leg till the patient complains of back or leg pain. Here also paresthesia or radiating pain, which is similar to the pain that the patient was experiencing, is highly significant. For a test to be interpreted positive, the radiating pain must radiate below the knee, as pain of the hip also radiates up to the knee. You also confirm with the patient that it is pain which is radiating below the knee and not hamstring tightness near the knee. A test between 30 to 70 degree is considered positive because before 30 degree there is a slack in the sciatic nerve which is taken up around 30 degree, and beyond 70 degree it is usually hamstring tightness or overstretching of the nerve, which can occur in normal patients also. We also look for any well leg or crossed SLRT. So what is well leg or crossed SLRT is you do the Lasegue test on the leg that is not complaining of pain, and if you get pain in the side of the pain, so suppose the patient was complaining of a right side pain, you lift the left leg and patient gets similar radiating pain in the right leg. This is known as crossed SLRT. This is suggestive of a large central disc herniation. After you get the Lasegue test positive, you have to slightly lower the leg. The pain should disappear. Then you dorsiflex the foot, which increases the stretch on the sciatic nerve. If this is positive, this is known as Bragard's test or Bragard sign positive. Following this, you again flex the knee and the pain should disappear. Following this, you apply firm pressure with the thumb over the popliteal fossa, over the stretched tibial nerve, and this is known as the Bowstring test, and if the test is positive, this is known as Bowstring test positive. So if all these signs are present, it is much more sensitive of a prolapsed intervertebral disc or a sciatic nerve stretch. Now in SLR, malingering or functional overlays are quite common. So some tests have been described to check for these malingering. One of them is the flip test. Here what you do is ask the patient to sit up on the pretext of examining the back of the patient. In a malingerer who was having SLRT positive at a lower degree, he may not have any difficulty. Whereas in a genuine patient, he will not be able to do it and the knees will get flexed or the patient will fall back. So this is known as the flip test. The Ayers test or slump test is also similar. Here you ask the patient to sit with his leg hanging at the edge of a couch, and then you ask the patient to extend his leg and you passively extend till 90 degree. A normal genuine patient will not be able to do and fall backwards, whereas a malingerer may be able to do this. This is also like a SLRT in a sitting position. The next test you do is the femoral stretch test or reverse Lasegue test, which is done in prone position, and in the prone position you flex the knee. Pain in the distribution of higher lumbar nerve roots is indicative of a high lumbar disc herniation, and this pain is usually aggravated by extension of the hip. So a reverse Lasegue test or femoral stretch test is indicative of a high lumbar disc herniation. Examination of spine should be followed by examination of the sacroiliac joints, examination of the hip joints, vascular status of the limbs, and per rectal and vaginal examination in cases it is indicated. So friends, in this video we described the local examination of the spine. The neurological examination will be described in one of the subsequent videos. If you like these videos, please hit the like button and subscribe to the channel for further videos. Also comment in the comment section regarding the topics you will like to be covered in the future videos. Thank you.